think, today immediate loading is a very booming thing because nobody wants to wait for long period of time, and everybody wants a quick solution with a great success results. How many of you think that? Fantastic. I can see some thumbnails, thumbs up. Great, great, superb, superb, lovely. And do you think the bicortical is always bicortical fixation of an implant, or a bicortical implant is always a topic of, hot topic of debate, where you are always contemplating whether to go for a standard placement of implants or a bicortical fixation. Always this been a good debate. How many of you think that, right? Great. So, as Dr. Ifra said, I'm Dr. Mayur Khanna. Today, after placement of 27,000 of dental implants in my career of 15 years, today I'm going to get you back some total insight about how you can place bicortical implants with respect to its osteotomy. Because if you see, the bone is not same everywhere. You will find sometimes D1 bone, D2 bone, D3 bone, D4 bone. All right. With respect to osteotomy, how you can engage the bicortical implants in a perfect way, you can achieve a great torque, and you can give a beautiful prosthetic set to your patient. That too, a retrievable, widely accepted, universally accepted prosthetics, not just cement retained prosthetic, with a digital protocols in this presentation. At the end of this presentation, my friends, you will see how I have completed certain cases with a digital way. That means by using a digital guides also. With that too, with respect to bicortical fixation. So stay with me, friends. As you know, this is Professor Branamak. Now, if you see his studies, what he said, that the highest success rate for placement of dental implant was in D2 bone, followed by D3 bone. Then the failures were high in D1 bone, and the maximum failures was in D4 bone. Now, why that happened? Why? Because he used the same osteotomy principles for all bone type. Because he was using same osteotomy for all bone type, definitely the D4 bone used to give up. And that's why she had yield this kind of results. So what happened later on? He concluded D2 will give you maximum success. Is it like that? Not always. And that's where the Carl Misch proposed different osteotomy protocols for dense bone and different osteotomy protocols for a softer bone. Now, all these protocols were usually designed for a unicortical placement or a standard conventional implants where you not necessarily have to engage the two cortical bone. Okay, what do you mean bicortical? Bicortical means we are engaging two cortical bone. Unicortical or a crestal cortical implants means you will just engage the crestal cortical bone. That's it. Okay, so this how then the osteotomy were evolved, I can say, right? So you can see in this, dense bone need more osteotomy and soft bone need less osteotomy. Okay. If you see the work of Branamak, he coined the term osseointegration on this particular X-ray. If you see this X-ray in detail, let's zoom it off. Okay. This is nothing but a bicortical fixation. So on this particular X-ray, he coined the term bicortical. Coined the term osseointegration, but he didn't notice that this optic chamber was impossible to retrieve. Was two reasons. One, definitely the osseointegration happened. At the second time, it was in bicortical bone. So when it was in bicortical bone, the amount of torque which is you get is very high, and when I try to retrieve it also, it's not so easy. And same findings was observed. Although this all titanium polished, this is all polished implant. Okay, this is titanium optic chamber which was absolutely polished, right, my friends? So this was a finding which was made by Professor Branamak. Now, what orthopedicians are doing? They are using same technique since hundreds of years, many decades. They are using bicortical implants. Okay, if you see, they are engaging the lateral and the medial cortical bone all the implants are not parallel to each other. They are rigidly splintered with the help of a fixation plate. Okay, this is not a plastic plate, right? And of course, there is a non-parallelism and they are loaded immediately. That means they ask patient to do the physiotherapy after 2 to 3 days, right? If this can happen, even if you see in this case, the patient is able to walk after hip joint replacement or knee joint replacement. And that is very common. You might have seen with your relatives. If this is happening on a regular way, then why can't our patient chew? This is also what concept we derived is derived from the orthopedician concept. Okay, if you see this, today we can do immediate loading by two ways. One is by placing a wider diameter implant in a smaller osteotomy. This is called corticalization of the cancellous bone. We can see on this. Okay, and another is if you don't have a soft bone which will condense the, or you have a very narrow width of bone, in that case we engage two cortical bone. Moment we engage two cortical, bicortical or multicortical bone, what happens? You get a fantastic torque, which is conducive for the immediate loading, right? So these are two ways to do the immediate loading, right? Now, when it comes to bicortical fixations or a bicortical implants, we need to know what is first cortical bone and what is the second cortical bone. So what is first cortical bone is the crestal cortical bone, which you can see in the maxilla and mandible. It is the same bone, right? Where the second cortical bone differs from area to area. In premaxilla, we have an anterior nasal spine, we have a nasal floor, we have a nasal buttress. Okay, we can see here it's a nasal buttress. Then we go posteriorly, here we have a zygomatic bone. More posteriorly, we have a pterygomaxillary junction. So these are the bone which is always available, okay, with the time. So even if the bone is resolved, this bone is always there to engage. So that's why this has become a favorite topic today, to engage this kind of bone in highly atrophied jaws, right? When it comes to lower mandible, anterior area, always the bone is fused, right? Because fused in the sense the bone is very dense over there. So the labial cortical and lingual cortical is kind of a thick bone, right? So this is always a D1 type of a bone. In rare cases, it is a D4 bone. In that case, you can engage the implant in the base of the mandible. That's a rare scenario. I'll show that, right? But majorly, you can place the implant in the intermandibular foramen. Posteriorly, you cannot just go directly traverse the nerve and engage the base of the mandible. That's not possible. So you have to either engage the lingual cortical bone or a buccal cortical bone. And rare scenarios, if the bone is resolved to the level of the nerve, there's two ways. Either you do the nerve distalization or you do the nerve bypass. These are two methods, right? Posteriorly. Let's see. This is a common way by which we can engage the implants. When you have a decent bone, here in this X-ray, in this animated image, you cannot see the zygomatic implants. But yes, this cases is everything is engaged into the as a bicortical implants, right? Now, if you see, you must be confused about D1, D2, D3 bone. So if you can see the first X-ray or the first animated image or first histological image, what you see is nothing but the dense bone, D1 bone. The whole bone is corticated, including the cancellous bone. There is nothing called cancellous bone. So we have a dense cortical bone and a very thick trabecular bone, right? That is what I can say. When it is D1, D2 bone, the cortical bone is little thicker, no doubt, but the trabecular bone is little loosely dense. In D3 bone, cortical bone is thinner, trabecular bone is very loosely arranged, and D4 bone, trabecular is almost like a hollow porosity. That's a difference. So you cannot have a same osteotomy technique for all the four bone type. That's why you need to have a different osteotomy method. And today I'm going to present you about that as well, right? So if you see, this is the first cortical bone and the second cortical bone. You can see that, right? Now, these are the certain drills. We commonly first drill, which is used, which I preferably use for bicortical fixation, is the first drill is nothing but the lance drill. Okay, the lance drill is 2 mm drill. It finds its own path through the cortical bone and also through the cancellous bone. So it is called pathfinder also. It is also called lance drill. The second drill which is used is a twist drill. Now twist drill is never a first drill to be used. Twist drill is basically used to expand the osteotomy in the second cortical bone. How? I'll show you. And then we have a sequential drill. This is called step drills. So it depending upon the diameter of the implant you're placing, you can use this step drill in a denser bone when you're using bicortical implant, right? So what implant I'm going to address to you as a bicortical implant is a cortical TPR implant from Quickdent. The best advantage of this implant is it can be used for nasalis in the anterior intermental foramen, in the premaxilla, in the pterygoid, in all in lingual cortical engagement, everywhere it can be used. Okay, it is ranging from 10 millimeter till 25 millimeters. So 10, 12, 13, 10, 12 and 14 millimeters, they will have a smaller collar height of polished collar height, whereas all the subsequent sizes, the long implants will have a longer polished collars. So even if the peri-implantitis chances are there, it will get nullified because of this polished collar. If you see the tip is very penetrating, that means the diameter of the first drill correspond to the diameter of the implant, right? And you have something called aggressive threads. It makes its own osteotomy into the bone. Now, if you see this particularly here in the thin bone cases, if you place a standard implant, this definitely will need a bone grafting. But when you place TPR in thin bone cases, this expands the bone and you can still place the implant. See, like what implant is placed is a 3.5 diameter implant and the bone is almost 3.5. And still there is a bone on the buccal and labial side. For a chance also a part of a labial bone, resorb because of XYZ reasons. Still the implant is having a polished collar. It will not catch peri-implantitis and it can prevent the peri-implantitis. That's another advantage of this bicortical implants. So it has a tip which is polished, which is has a crestal area which is polished. The tip is polished because you have to perforate the second cortical bone and you may sometimes reach or cross the second cortical bone, right? So that's why the tip is polished. So in this case, you can see very thin bone. Still the implants are placed on the palatal side, right? And this is called palatal placement. So in this case, if you can see, the part of the polished implant is exposed, but it is okay if it is exposed, polished part. If the rough part is exposed, definitely one needs a membrane and grafting. I will not recommend that. But if the polished part is exposed, it can stay in contact with your soft tissue. That's a greatest advantage of bicortical implants because these are specifically used for resorb bone cases. Okay, let's see how we do the osteotomy in D2 bone in anterior maxilla and pterygoid region. This is the first drill I said it will first traverse the first cortical bone and then second cortical bone. It will perforate the second cortical bone, right? After this, you will place the implant. But before this, you have to measure it with the depth rope. Okay. This is something important. Again, same way here, you will retrieve it. And you for 4.2 diameter implant, as I've told you, this twist drill is used to do the apical, that is second cortical preparation. You have to expand the osteotomy in the second cortical bone so that your implant goes exactly in that region because it's a wider implant. So this is what is needed, right? And this is a depth probe which is ideally used before placement of implant. This is some issues in the animation, but ignore that. I'll show you same thing in this cross section. See in D2, D3 bone, and I will show the osteotomy procedure in D3 and D4 bone. Okay, let's check that. I've done the perforation. I've used the depth probe, I measured it, and now I place the implant. This is very important. Now, what is problem is happening in D3, D4 bone is when you're perforating is okay. The cancellous bone is so soft that if you don't follow the direction of osteotomy with the direction of implant placement, you may deflect the implant towards a little bit on the palatal side. You will go and reach the palate, the second cortical bone instead of reaching the perforation, and you will keep moving round and round. This is a problem. So what is to be done in that case? You have to expand it with the 2 millimeter drill and follow the direction of implant with the direction of the placement. That should be absolutely the same. Otherwise, you will keep moving against the resistance, because unless you do this particular step of engaging your apical part of the implant into the second cortical bone, you will not get torque. Believe me. Okay. So that's very important. This is a common basis for the premaxilla. Okay. What about the nasal buttress? If you see, this is the nasal buttress. And we also can see is something called nasal floor, right? So you can engage the nasal buttress in two ways, either by placing the implant parallel to the anterior wall of the sinus or placing the straight. Or the third way of doing that is to trans-sinus canine buttress implants. Okay, through the trans-sinus. Okay. Now, if you see this here, this is particularly done through trans-sinus, especially the implant in the right quadrant, middle implant. It is done to trans-sinus. Now, this is done in 2018. Okay, with a cortical TPR implant. These are all multi-unit abutment. This is screw retain prosthesis. Now, this is a 7-year follow-up. Can you see the bone formation over there? This is fantastic bone formation. Patient is heavy smoker. Heavy matlab tremendous heavy smoker. 20 to 25 cigarettes a day. The bone loss has happened, of course, because of smoking, no doubt. But it has gone and it stayed limited to the crustal, polished area. That's it. Nothing beyond that. That's the advantage of bicortical implants. If this would have been a rough surface implant, it would have definitely got infected and it would have given up, also possible. Okay, for especially for this case. Now we finished our premaxilla. Let's go to zygoma. It is a very short presentation, so I will be little brief about that. This is the target zone of the zygoma. So here zygoma is also kind of a bicortical implant. We just place the zygomatic implant. This is also a bicortical implant. If you see, this is being placed. Now, though you cannot see the facial aspect of the zygoma when you are doing the surgery in the local anesthesia. Okay. So what is bicortical? Here also same thing. With the drill, you're drilling, you're removing, you're done the bicortical perforation. You will measure the probe. After measuring the probe, you will select the implant and you will place the implants. Okay. Once you place the implant, it should be in the tooth zone so that you don't have a very bulky process. You can see over here, there is no bulky processes, right? So it should be in the tooth zone. Different burrs are used, different drills are used, diamond burrs are used to create osteotomy channels for the implants. This is a separate topic altogether. We will talk about it sometime later, but this is just a bicortical fixation. Also, this thing, right? Coming to pterygoid implants, if you see pterygoid implant, this arrow which is showing you different pterygomaxillary junction, we need to understand what is the volume of the junction. Sometimes the volume of the junction is very wide and sometimes the volume of the junction is very, very low. Okay. So pterygoid implant has to be managed by understanding the anatomy and anatomical variation. So let me show you what is this is the height of the pterygomaxillary junction. That's a width. And this is the thickness, if you see specifically. Okay. So unless we know the variations in all these three parameters, we will not be able to understand. We will not be understand what is the volume of the junction. We need to understand. So this is a particular volume parameters which show whether the junction is adequate or inadequate. So if you have a height more than 7 millimeters, that means it is adequate. Width more than 7 millimeters is adequate. Thickness more than 5 millimeters is adequate. What does that mean? That means you have two sites for placement of pterygomaxillary implants, right? Does it mean you have to place two? No. It is for backup. When you have inadequate height, okay, so it means your height is less than 7 millimeters, width is less than 7 millimeters, and thickness is less than 5 millimeters. What does that mean? You have only one site for placement of the pterygomaxillary implants. And you have to be very cautious because you don't have a backup now, right? So this is what exactly. Now I'll show you briefly about the vertical directions of the pterygomaxillary implants. Now, sometimes the junction is located very close to the crest of the tuberosity, that is 1 to 5 millimeters. Sometimes it is located little superiorly, 5 to 10 millimeters. Sometimes it is located very, very superiorly, more than 10 millimeters. Now, chances of error are very high when the location of the junction is located 10 millimeter above the crest of the tuberosity. Whereas, when the resorb case says when it is very close to the junction, it is more easy. So you hope you understand. More resorb cases are more easy to treat, or superiorly placed pterygomaxillary junctions are more difficult to treat, right? This is the what gives you idea about the vertical direction of the pterygomaxillary junction. Okay, now these are the certain variations. If you want to assess what I'm saying, type 1, type 2, type down into the your Google Chrome, just check Kerner's pterygoid classification. You may get certain article. If you don't get it, you can connect me on Instagram. I will try to send you some articles it will be definitely of a high value to you to understand the pterygomaxillary junction variations. Okay. Now this is type 1 and type 4. What is that? Both are located 1 to 5 millimeter, but one is having a site for two placement, one is having site of only one placement. Okay. And the angle is what? Is more obtuse. Okay. Very, very, steep angle is there. It's not straighter, it's very steep. So maybe 45-degree multi-unit is needed in this case. Whereas in type 2 and type 5, it is junction is located 5 to 10 millimeter above the crest of the tuberosity. So angle is little less steeper compared to previous, right? So maybe 30 degrees needed multi-unit, maybe, yeah. And sometime the junction, as I told you, is located very superiorly. If you miss it, probably there is chance you may come out of the distal wall of the tuberosity instead of going into the junction. That is one type of error. So you have to be right into the junction. So here, if you see, the angle is very less steeper. I hope you are getting it. If you are getting it, please put down yes into the comment box or thumbs up. That I will try to understand that you are assessing it properly. Okay, you are getting it properly. So here, super. So here you can see the angle is less steeper here. So this is very, very important to understand. So now I've told you what is needed for pterygoid placement. Of course, the first drill is nothing but a lance drill. Sometime in denser bone, you will need twist drill. You will need a depth rope. Of course, you will need a pterygoid osteotomes. And diameter of the implant, as I've told you, 3.5 and 4.2. These are the common length which you get. So common length used for pterygoids is 16 to 25. Not anything less than that. Very resorb cases, very thin bone, 14. I have never placed anything less than 14 in the pterygomaxillary junction. Okay. And common is 18 and 20. What is pterygoid implants? You drill against the resistance or you tap against the resistance. That means if you see this is a soft bone. What you see is soft bone is the tuberosity. So with the tuberosity, I will first just do it with my hand and then I will tap it and I will perforate it. Okay. So see, after tapping, I get a resistance. After inserting with my hand, I'm getting a resistance. I'll perforate it with the osteotomes. I'll use a depth rope and I'll measure and I'll place the implants straight away. Now that's a very simple thing. Traverse the soft cancellous bone with the pterygoid osteotome because it is tuberosity is having a soft bone. Feel the resistance. Tap it if you're doing with the osteotomes. Okay. And then you place it. But sometimes, rarely, you may find that tuberosity is also very dense. In that case, tapping is definitely not a great option. So what is the option? In that case, tap, it is resistance is happening. Just take the drill, perforate the drill. Okay, measure the implant, osteotomy, choose the right implant and place the implants. This is how you can overcome when the tuberosity is having very dense bone. Okay, so drill against the resistance or tap against the resistance is most important sutra for pterygoid implants, right? And what directions you have to follow? You have to follow the direction of the medial hamulus of the medial pterygoid plate. Okay, not going like into details because it's itself is a huge topic. Sometimes you may do a wrong mistake when the pterygoid implants are placed. Pterygomaxillary junction is located very superiorly, so like this. Okay, so you have to follow the medial hamulus. This when you're placing, like maxilla is done with a bicortical fixation, osteotomies. When it comes to intermental foramen, you can see the bone is very dense. Here, you don't have to do one drill and place the implant. If you do one drill and place the implant, what will happen? Ideally you can place conventional implant, but if you want to do bicortical fixation also, you cannot do because the bone is so dense, you don't have to go into the base of the mandible. I hope you're getting that. It makes sense. You don't have to place bicortical implant. So here, either you can use bicortical implant as a conventional implant and place it, or you place straight away conventional implant. It's up to you. But you cannot do with one drill or two drill. You have to use step drills now. Now, after this pilot drill, okay, or lance drill, you will use a step drill. Now, after first step drill, you can probably, use a next drill for a half length for 3.5 diameter and a full length for 4.2 diameter. And I'll place straight away 3.5 diameter. Here I will use third drill and do it half osteotomy and I'll place the bicortical implant of 4.2 diameter. If I want to do bicortical implants, right? Same way you have to do for the conventional implants, right? What about D3 bone? Sometimes anterior bone in mandible can have a very soft bone, like this case, right? In that case, see, here we still place the bicortical implant. We didn't reach anywhere in the base of the mandible, but in spite of D3 bone, we could achieve a good torque. We did immediate loading and we have a successful follow-up also now, right? So why? This is nothing but here, this is a soft bone. What we have to do in soft bone, we have to do one single drill and straight away place the implant, and this is called corticalization of the cancellous bone. That means I am doing under osteotomy and condensing the bone with the bicortical implant. The implant itself is a working like a denser bone, it itself condenses the cancellous bone. Now sometimes the bone is so soft in anterior mandible that you still cannot get a good torque. You'll have to do delayed loading in that case. But suppose your patient have flew from UK or some other place and they have you have committed that you have to do immediate loading. That time you cannot, after committing, you cannot do that. Either you commit before or you don't. But you cannot do that. In that case, what is a good solution is to engage the base of the mandible. Now here, okay, so this is what I am trying to say. When the bone is D4, you cannot get a good torque. In that case, you have to go for a basomandibular implant. Okay, if you see this is a soft bone case. Here we will go and perforate the base of the mandible. But again, because the bone is soft, we will follow the direction of the implant with the direction of osteotomy. Otherwise, I may go and deflect like the one on the right hand side, see, or left hand side. If we deflect, this is, you're not going to get the torque, my friend. You will keep moving against the bone resistance. So you have to remove, use the twist drill to do the apical perforation, that is apical osteotomy preparation in the same directions, and then place the implant carefully in the same directions, right? Then only you will get the good torque. And believe me, once you engage the base of the mandible, your torque will be like heavy loaded torque, very heavy torque, right? And you can get the immediate loading kind of stability with this. Okay, this is a very soft bone case, right? But at this extent, never ever perforate the lingual side of the anterior mandible, my friend. This is absolute contraindication. So you are expert, then do it. Now another way to avoid all these things is to use for a guided approach. Okay, guided surgery is a very good option for such kind of cases. But sometimes you need to know, you should have such a long drill, so you can go for a pilot guided as well. Okay, because that is also another option which I'll explain you about later on. Okay, now many times when it comes to posterior mandible, you are safe enough to place 4 implants in the anterior mandible and give cantilevers, but these cantilevers can create a problem, not now, in future. So in order to avoid that, there's always a good option to place one implant posteriorly, even if the bone is not good enough, and that is called linguocortical implant or a linguomandibular implant. So we tilt implant towards the lingual cortical bone. Now in this case, if the height of the implant bone is only 6 millimeters, can you see? Now the vertical height is 6 millimeters. I cannot place straight implant vertically, like minimum 5 millimeter implant, but I could place 10 millimeter implant because I tilted this in 2 direction. I tilted this in buccolingual direction as well as mesiodistal direction. So I could place, accommodate 4 more millimeters, and I could go and engage the implant. Like for example, in this case, okay, here we could place around 10 millimeter of implant. This is on the palatal side. Okay, see here the tilt. Okay, it is just not tilted in one particular direction. It is mesiodistally and also buccolingually. Okay, so this is nothing but the linguocortical implants. Okay, so this is another example of a linguocortical implants. When you have sufficiently not good bone to do the compression of the cancellous bone, especially in the posterior mandible, and not good height, then this is a very good option to engage the lingual cortical bone and get an immediate stability. But I don't recommend this for a single tooth replacement, right? So it is only good idea when you have multiple teeth replacement, or at least a full mouth case, a full jaw case. So this is a lingual cortical. Now here, if you see lingual cortical, bicortical. Bicortical means you have to perforate the second cortical. So my decent advice after placement of so many implants is not to use any rough surface implant for this kind of procedure, which is having a tip which is rough. Why I recommend very frankly the cortical TPR? Because cortical TPR has a tip which is non-cutting and it is polished. Yes, TPR tip is not cutting. The threads are cutting and you're not supposed to come out. Only the tip may come out. Sometimes the cortical thickness is good enough, even the tip will not come out. It will stay there itself. Okay, so this is what I'm showing you. You have to use a finger to retract the vital structure like glands over there. Your nerve will be very far, no doubt about it, or your lingual arteries will be also very far in the posterior mandible. Okay, beyond 5. You go, you perforate. Once you perforate, you will come to know. You take out, you check with the probe. Okay, and you use the second drill. Okay, like this. After doing the second drill, you measure it and you place the implant and then the multi-unit abutment. That's how you can do the linguocortical engagement. Of course, this is the most important step. Many a times, when you're doing bicorticals, you cannot just measure into the CBCT and fix the length of the implant. When you are doing this, you have to have the sufficient stock with you. You have to have the depth probe so that you can accurately measure the length of the osteotomy. Okay, most common implants to be used is 3.5 by 12 or sometimes 14 and rarely 3.5 by 10. Okay, it all depends. Now see, because the bone is slanting, I am also placing at a slant. I don't have to wait or worry about the crestal bone because my implant is at the slant. Once I remove, you will see that. Okay, see, there is a bone on the buccal side in spite of the slanting bone, right? So that's a lingual cortical. But however, in such cases, the lingual cortical is not possible. Okay, so that's where comes a bucco-mandibular implants where you do typical now bypass like what you see in this case, especially the right side. The implant is placed on the buccal aspect of the now. Properly. Definitely, this is a blind procedure. I will show at the end of the presentation, I'll show you how we do it today with a guided approach. Now, coming to the prosthetic evolution, initially we used to do bicortical implants with, single piece. Now, single piece, only problem is you have to do it with the cement return processes. However, today it is possible to do everything with a digital prosthetics, that is digital scan body, a digital analog. You just scan, send it to the lab, and there's something called this is for multi-unit level, but also for implant level there's a beautiful thing that is called smart tie base. Okay, so where you can correct the angle channel. Okay, I'll show you one small case if possible. Okay, let me show you. Now this is a central incisor case. This is a common problem. You place implants, no problem. You place osteotomy, you place implant, this implant is being placed. See, the only one drill is done on the palatal bone. That drill is enough to catch the implant, and implant is just going in. Implant just catches the bone. This TPR implant is a mind-blowing implant. It just catches the bone like anything. Okay, and only one has to have a basic learning curve. One who is very used to place single piece bicortical, I mean, they will love it. One who is like never got a feel of second cortical, they just fall in love. So I just frankly I just love this particular design. Now this has been placed. Okay, if you see, the access hole is coming on the labial side. If I want to give screw return process, what will happen? My access hole will be on the labial side. Clear? So is it an aesthetic option? No, definitely no. So there is something called, see, this is access hole coming on the labial side, right? So there is something called cross channel tie base. It changes your access hole from labial side to the palatal side by 20 degree, not more than that. If your implant is more than 20 degree, you cannot get the access hole on the labial side. If it is less than 20 degree, around 15 degree, you can shift the access hole on the palatal side like this. Okay, so you have to be as straight as possible. following the anatomy of the bone. You should not be like, tribase is the SE, you will go like this direction. No, you have to be as straight as possible. Still, sometimes you need a correction of 15 degree. This is possible. And see, here we did that. This is the tribase just for a trial to show you. With the CAD cam, exocad, he is shifting the access hole from straight to the palatal side, from incisal edge to the palatal side now. Okay, see, and we got in the same tooth, we got a access hole with a palatal approach. This is called angle channel tibase, cross channel tibase, or angle correction tibase, any name. But this is now available with the QuickDent system. This you can also get it exchange at just for your standard stock abutment. That's the wonderful thing. You don't have to pay something extra for this. This is a wonderful for single tooth restoration, especially anteriors, and you want to give a cross channel or a screw return option, right? So today that is practically possible. I'll show you one immediate temporization case with a prefabricated prosthesis. That means when we started this case, before starting this case, our prostheses were ready. Now, this is a very fascinating thing for all of you. Like, so how we do that? Now, this is a patient. Day one patient comes, we just scan upper and lower completely. Scanning is done. Okay, this is the scan. This is first scan is sent to the exocad. Okay, exocad, on the exocad on this particular tooth, he will do all the teeth setting, teeth arrangement. He'll modify it and he'll make an ideal teeth in the exocad. Okay, this is superimposition of a new prosthetic design over on the old scan, pre-op scan. Clear? Now, whatever things we have the DICOM file of the patient, and we have something called patient cut a new teeth design. We will upload those things on QuickDent 3D software. This is a new software interface where you can design guides for the patient. Guides means now the best part of this QuickDent, they have taken an initiative to train dentists to how to use guides for their patients. You don't have to depend on others now. You can make your own guides by yourself by using this particular software, right? So after this, you load this, then you do the surgical planning, assessing either you're going into right pterygoid region, right premaxilla, ABCD, everything you will do this. Okay, this is a beautiful part of this software. It is also open software. You can use it for 150 dental implants, not just QuickDent. So that's the best thing, right? Nothing, it's not a closed software, it's open software. Okay, once this is done, what I will do, I will prepare this is a bone reduction guide. Okay, on this is a bone reduction guide that I have to reduce this much of bone. This guide is nothing but the primary guide. On this guide, there will sit a osteotomy guide, which is called secondary guide. It's also called a stackable guide. Okay, so this is done. This is fixed on the second. Now, these two things are being sent to us. Clear? Now this, okay, did you get it? Now, on the bone primary guide, that is the bone reduction guide will be there. Over this, the secondary guide will sit, and over the secondary guide, you will place it and you will do the osteotomy. This is what we do. Now, at the same time, this, what your technician have designed is also given. We have that data. We also put that on your primary guide, okay, with your teeth design. And this will fit on your primary guide. Like for example, this thing. So your primary guide, your design teeth is also fitting now on your primary guide. So this is an advantage of stackable guide. What stackable guide means? Your primary guide can take osteotomy guide. Your primary guide can take also the teeth. That's the beauty of this particular software or stackable guides, right? Now this, whatever we have done is this osteotomy guide is a pilot guided surgery. Okay, this is only, that means only I will do one osteotomy and I will remove it. One osteotomy, and rest of the osteotomy, if required, then I will do the with after removing the guide, and my implants is also placed after removing the guides. This is called pilot guided surgery. Okay. Now, what is fully guided surgery? Even your implant or the final drill is going through the this takeable guide, and your implants are going through the guides. That is called that is called fully guided surgeries, right? So this is done for the mandible, maxilla implants. The guides is taken out, implants are placed with the pilot guided approach on the same primary guide. we have attached the multi-unit everything. Now, after this, we have used this putty and just got the indentation of the multi-unit. Now, this is sent to the laboratory. We have taken the standard scan, he printed the model, and on this model, the same teeth on which the indentation was hole was made, and they catch the tie bases in the lab itself. And why? Because it is very important to give a under surface of the process should be very, very fine, even if it is a temporary. This temporary is given to the patient on day 2. So I'm not waiting for long. Day 2, I'm giving the patient temporary prosthesis. That's the beauty of this particular process. Okay, this is done. Transitional process is given to the patient. Now what? Next. After 2 months, patient comes. First of all, we do one thing. We will scan the temporary. This will become my pre-op. After removing the temporary, I will attach the multi-unit. On the multi-unit, I will attach the scan bodies, and I'll take the upper and lower scan. These 2 things are done. Now, what is technician is doing? Now, the technician will prepare the final processes by merging the both data, and he will give a final process. This is the final process of the patient. Okay. So this is the follow-up of the patient, right? I'll show you one more case which we did recently because the time is pressing now. I have only few minutes. Now, this case, if you see, the nerve is very close to the crest. Now, this is nothing but a pilot guided nerve bypass. Okay. This is the first case where we did the pilot guided pterygoid. See here, we are just placing and we are doing the drilling. Zoom in, zoom out. You don't have to worry. After this is done, this is tooth supported. Okay, it's the same case which you can see over here. And we got the implant, we removed the implant. This is a quick-dent cortical TPR implant. The new implants come with a colors, that is 4.2 have a blue color and 3.5 have a crystal pink color. So that's a beautiful thing again. And you get a good torque and you stop. Okay, this is one thing. I will also show you one fully guided osteotomy. Now, this is a fully guided surgery, okay, where you can just, see, this is a fully guided kit by the Quick Dent. So, this is just a center drill. First, you will drill at the center, okay. So, someone is worried that while placement of implant, if I may go here and there, then you can go and learn the fully guided osteotomy. Here we are doing sequential drilling in terms of length. First, small length osteotomes drilling were used, then long length drilling were used. Now this is a very long drill, like 20 millimeter is used. Okay, it's done, removed, the perforation is done, and the implants are placed through the drill. This is just to give you a approximate orientation, and see the tip of the implants coming out of this thing. Okay, this is just on the model to show you more clarity because pterygoid is not clearly visible. Now, this is last course which we did with our lot of participants where they got an insight to see about all these procedures in details. Now, here the nerve bypass, I've told you the osteotomy guides, and here this particular right side lower implant is seen to be traversing the bone and traversing the nerve and the base of the mandible, but it is actually both we have done in this done case with the nerve bypass. Typical nerve bypass. See, at level of the crest. Yesterday you saw, you guys have attended this immediate. So we are asking whether the patient is having any numbness or not. Right. Yeah, with the help of surgical guides, we have done the nerve bypass. Now we are just asking patient what is the current status. मैडम आपका यहाँ पे इम्प्लांट हुआ है, आपको यहाँ हैवी है कहीं पे नहीं, जरा भी है आपको जैसे. So I hope you can appreciate this. She is not having any numbness. If you're getting this, type down into the comment box that you are getting this. This is a typical nerve bypass which has been done with a guided blind approach. I have not done anything. I have not done any heroic thing. Just using a quick then 3D software, creating a guides, and just drilling and placing the implant in right direction. That's it. Implants are placed in the buccal aspect. Clear? See, with the quick cortical TPR implants, also called as BITP. So that's the advantage. If you think all these cases are done by me because I have done so much of experience, no, but these are done by a lot of, it is done by our student. So this is one of the doctor who is placing pterygoid implants. Okay, this is like one-to-one mentoring we do, where we ask them to place the implant. Either some can place pterygoid, depending upon what, when you are registering, how you are registering, and what. So you, if according to the luck, you will get to place selective implants, and you will go and engage the second cortical bone. You will get that habit, and you'll start placing implants on its own. Okay, this is one of the doctor from Gujarat. He's placing the pterygoid implant. If you see. So he is doing the pterygoid implants, right? So I am guiding him after osteotomy. He is being placing them. We are telling him how to do it. Right? So it's not that you can't do it. Someday I was also listening to some webinar. Na? So if I can do it, then you can do it. Anyone can do it, right? So this is what is he's doing. He's placing the cortical ZTP, that is a Zygoma implants. Okay, some similar type of workshop we are coming up in the month of November. You can just note down this number if you're really interested. This is a 3 days workshop. The number is 900 4466739. I repeat again, its number is 900 4466739. Here we will be giving you all insight about bicortical implants, zygomatic implants, the pterygoid implants, how you can engage the lingual cortical implant. Because today I just spoke in 45 minutes, which will be given in details about 3 days. I hope this recipe will will be a high earning, a high profitable skills for you, and that will definitely increase your revenue by multiple times. Believe me, like many doctors who have joined it have become foolproof, and they have now millionaires also. Of course, we are going to give you insight about guided implant surgeries. This is a new thing which is going to come in this workshop, unlike before previous workshop. That's something new this time for sure. With this, okay, so some transformation again done by my students, everyone doing a lot of transformation, some from some batch. Okay. You can follow me on my Instagram, Dr. Mayur Kernar. And I would like to say thank you to Dentist Channel Online and Quick Dent Implant System for inviting me to give you insight about this webinar. And I'm sure I'm open for the Q&A session. Yes, Dr. Ifra, if there's any questions, I will be happy to answer them. Thank you so much.
Yeah. Thank you so much, Doctor. It was a great and an insightful presentation, and you provided, good videos and images so that we can understand and correlate better.
Thank
So,
you. Thank you.
meanwhile, yeah. Meanwhile, I request the participants, if you have any questions or doubts regarding the presentation, drop in your questions in the Q&A box so that it can be answered. So, we have a question, Doctor. The first one is bicortical engagement necessary for delayed loading in adequate width bone?
Adequate width of bone. Yeah, see, bicortical implants with when you have an adequate bone, it's up to you whether you can go for a conventional implants also, you can go for a bicortical implants also. Well, if you are going for conventional implants and if you think you are going to get a good torque, then you can go for implants like Aussie. But you have to be very cautious whether the patient is having a good oral hygiene or not. If with the time, or smoker, if with the time the crustal bone loss is happening because of any reasons, because of non-maintenance or surgical errors, there are like 7 8 reasons for crustal bone loss. If you cannot control that, then there is a chances the periimplantitis may happen, whereas the bicortical implants will definitely in that case will have a superior edge, because the crustal polished area will always prevent this kind of periimplantitis issues. So I don't think so it's a it's any negative effect if you're going for a bicortical implant, even if you have a standard bone cases. Yeah.
All right. I hope that answers your question.
Yeah.
So the next question is any reference books for bicortical and zygomatic pterygoid implants?
Uh, Reference books for bicortical and zygomatic. So we have our notes particularly. We can definitely it will be available soon. My suggestion is you can, if you are today instead of book, you can go for a lot of videos. So QuickDent YouTube channels have a lot of videos, a lot of educational videos. You can refer them, so it will be in front of you. You can open anytime and you can just go through that. When it comes to book, shortly wait for some time because I'm coming up with a beautiful book coming on this particular topic, which will address all the questions.
All right. So if any more questions, you can just type in your questions in the Q&A box. All right, doctor. Would you like to add some take-home points?
Sorry, for me?
Yes, yes.
Yeah, so the
Any
thing is,
take-home points, like few
so
key
the take home
points?
points is today, when it comes to immediate loading, there's nothing better than a bicortical implants, especially with the cortical TPR. It's a wonderful implants, especially when it comes to resorb bone cases. You definitely, it will be an overage. I have a follow-up of more than 7 years, 8 years with this particular designs, and it works wonderful and lovely. When it comes to pterygoid implants, very common problem with pterygoid implants is the width of the tuberosity is very narrow, and many systems have a pterygoid implant which is minimum 4.2 diameter, which can create in future some kind of issues with respect to the shrinkage of the soft tissues, or you know peri-implantitis, because there also the collar length is polished is around 3-4 millimeters. So in there don't have any pterygoid implants for 3.5 diameter. So this is the only system which is having a US FDA approved 3.5 diameter for pterygoid implants, because this has passed all the fatigue testing. So you can easily rely on this particular implants with around 45-degree multi-unit abutments, that to a collar height of say around 4 millimeters, which has got a FDA approval, and it can easily stay there for lifelong. Yes.
Next question is, so as you have shown in the image, the D3, D4, how can we predict the correct direction of placement as it is a blind procedure?
In D3 and D4 image, how we can predict the correct dimension? So see, the thing is that when you are placing in D3, D4 bone, no, the most important thing is you should be in the center of the osteotomy. Okay, your drilling should be in the center of the bone. Your osteotomy should be exactly in the center. If you are way much toward the labial side or way much toward the parietal side, you definitely will have a dehiscence of the implants when you're placing that way. Second thing is, when you go in the center of the bone and your osteotomy is in the center, you go and perforate it. In that case, you have to follow the direction of the osteotomy. That means you place the drill, take out your implants, and when your implant is loaded in your hand, or your I prefer usually handle placement, you remove the drills. Okay, you remove the drill and then you place it. In that case, initially, if you do too much of like this, you're changing the direction. You be gentle when you're doing in soft bone, so you don't change the bone. Only your crestal bone is the bone which is going to guide you in the right direction. If you mash up the crestal bone, your direction will change. That's the more important thing. And this can be also be avoided if you're placing guided, and if your CBCT calibration is accurate, the guided is 99% perfect. If the guide preparation is perfect, if one don't fail to block the undercut of the guides, still you can have a problem. That's the major problem in the guided surgery, because in guided surgery you don't prepare the guide, it's someone third technician is preparing the guides, and the way the guide is supposed to place on the bone, it is not fitting because he have not removed the undercut on the guides. So on the patient mouth, guide doesn't fit the same way it's supposed to be fitting on the software, right? So it is very important for you to learn how to design a guide, how to design a treatment planning into the software, and that's where we are coming up with such kind of trainings, where you can learn all these things. So this is a guided training, so you be in touch with the quickdent Instagrams and all this thing. You will get constant updated things about the new aspect coming up. Yes, any more questions?
Any more questions? You can just type in your questions. Okay, I guess that's it for the questions, Doctor.
Yeah.
So, with this note, we'll be ending this session. So, thank you to all the participants. And once again, thank you, Dr. Mayur, for being our guest speaker today. The session was quite informative and insightful. So,
Thank you. Thank
yes,
you, Dr.
thank you.
Eva. Thank you. Thank you all of you for being here Saturday evening. I know this is a party time, but still you took your time to be here to get some new knowledge, and I'm very sure you will get definitely value out of it. So thank you so much. Thank you everyone. Thank you Dentist Channel Online for conducting this workshop. Thank you so much again. Yeah.
All right, Doctor. Thank you.
Thank- Yeah.